This recorded lecture will be going over Chapter 37, Care of Patients with Diabetes and Hypoglycemia in the MedSurg textbook. Type 1 diabetes is secondary to a malfunction of the beta cells of the pancreas. Diabetes mellitus results in the body's failure to metabolize sugars and starch. Nearly 34 million Americans, that's approximately 9.4% of our population, have been diagnosed with diabetes mellitus, and millions more have diabetes and don't know it. The cost of treating diabetes in the United States is approximately $327 billion per year. Type 1 diabetes, formerly known as insulin-dependent diabetes mellitus, accounts for about 5 to 10% of all cases. Type 1 diabetes occurs when the body's immune system destroys insulin-producing beta cells. There is no known way to prevent type 1 diabetes. People who have type 1 diabetes will require injections of exogenous insulin, this means from outside of the body, to maintain their life. This is because they produce little to no endogenous insulin. This means produced on the inside of the body. In general, people with type 1 diabetes are more prone to serious complications, ketosis, associated with an excess production of ketone bodies that can lead to ketoacidosis. Type 2 diabetes, formerly called non-insulin dependent diabetes mellitus, makes up about 90 to 95% of all known cases of diabetes. This is believed to begin with insulin resistance. This is where insulin interaction with glucose becomes less efficient, therefore glucose metabolism is abnormal. Type 2 diabetes tends to develop later in life compared to type 1, and patients with type 2 will rarely develop diabetic ketoacidosis. On page 883 within box 37.1, we can see symptoms of type 1 and type 2 diabetes. Type 1, you'll see extreme thirst, this is polydipsia, frequent urination, polyuria, and extreme hunger, polyphagia. You'll also see rapid weight loss, irritability, weakness and fatigue, and nausea and vomiting. In type 2 diabetes, you could possibly see polydipsia, polyuria, and polyphagia. More commonly, you will see excessive weight gain. There will be a family history of diabetes mellitus and possibly poor healing of scratches, abrasions, and wounds. The patient might have blurred vision, itching, drowsiness, increased fatigue, or tingling and numbness in the feet. Latent autoimmune diabetes in adults, also known as LADA, is a form of type 1 diabetes. It is believed that the presence of islet cell antibodies in the blood, which should not be present in a healthy individual, will eventually destroy the beta cells and insulin production will cease. Patients with LADA are typically not overweight. They have no signs of metabolic syndrome, and they may have a history of personal or family autoimmune disease. This diagnosis will be based on 3 criteria. Onset should be after age 30. Islet cell antibodies should be circulating within the blood, and insulin will not be required sooner than 6 months after the diagnosis. These patients can be misdiagnosed as having type 2 diabetes. Gestational diabetes can occur as a result of the stress of pregnancy. This can be treated with diet, oral hypoglycemia agents, or insulin. The 2021 guidelines from the American Diabetes Association recommend the use of insulin instead of oral agents. Glyburide and metformin, the most commonly used medications, can cross the placenta to the baby. After pregnancy, the condition should be reevaluated because approximately 35 to 60% of women with gestational diabetes are diagnosed with type 2 diabetes in the years after their delivery. At least 4 sets of factors will influence the development of diabetes. This includes genetic, metabolic, microbiological, and immunologic. Genetic factors are included in the etiology of diabetes because diabetes will run in families. Emotional or physical stress can unmask an inherited predisposition to the disease, probably as a result of glucogenesis induced by increased production of hormones from the adrenal cortex, especially the glucocorticoids. Perhaps even more significant than the metabolic factors is the association of type 2 diabetes and obesity. About 80% of patients with type 2 diabetes are obese. This means more than 20% are above their ideal body weight. There is a higher incidence of type 2 diabetes in people who lead a sedentary lifestyle and eat a high-calorie diet. With weight reduction and increased physical activity, blood glucose can be restored to normal levels and maintained there, hence the importance of diet and exercise in the management of type 2 diabetes. Type 1 diabetes is classified as an autoimmune disorder. The ADA recommends screening all adults, especially those who are overweight and have one or more additional risk factors for type 2 diabetes. This should begin at age 45 and be repeated every 3 years. A hemoglobin A1C, fasting plasma glucose, and a 2-hour 75-gram oral glucose tolerance test should be the appropriate screening methods. In addition to lab tests, the healthcare provider, depending on the clinical signs and symptoms, will use that information to establish a diagnosis. The classic signs and symptoms of diabetes mellitus, regardless of type, are related to an elevated blood glucose level, also known as hyperglycemia. Hyperglycemia increases the concentration of intravascular fluid, raising its osmotic pressure and pulling water from the cells and tissues into the blood. This leads to cellular dehydration. The kidneys will try to get rid of this extra glucose within the urine. This loss of glucose in urine is called glycosuria, and it also causes electrolyte loss. Cellular dehydration will cause thirst and a resultant increased intake of water, known as polydipsia, and the osmotic diuresis increases the urination, known as polyuria. Hunger, or polyphagia, is the result of the body's effort to increase its supply of energy, even though the intake of more carbohydrates will not meet the energy needs of cells because insulin is not available or effective at allowing the glucose into the cells. Fatigue and muscular weakness will occur due to the glucose not being metabolized properly. Weight loss in patients with type 1 diabetes can occur for 2 reasons: a loss of body fluid, and in the absence of sufficient insulin for the use of glucose, the body will begin to metabolize its own proteins and stored fat for energy. The oxidation of fats will be incomplete, and fatty acids are then converted into ketone bodies and acetone. When the kidney is unable to handle these accumulated ketones within the blood, ketosis then occurs. People with diabetes are prone to infection, delayed healing, and vascular diseases. This is primarily due to the hyperglycemic environment. Another contributing factor to infection and delayed healing could be the decreased blood supply to the tissues due to atherosclerotic changes within the blood vessels. There is no cure for diabetes mellitus. The goal is to maintain blood glucose and lipid levels within normal limits and to control these factors to prevent further complications. Studies have demonstrated that there are benefits of tight glycemic control. This means control of glucose in the blood for people with type 1 and type 2 diabetes. Patients attempting tight control will follow an intensive therapy plan of blood glucose testing multiple times a day, as well as insulin injections or an insulin pump. There are some risks associated with perfect control of blood glucose levels, and tight control is not indicated for every patient. The most serious control issue is hypoglycemia, or insulin reaction. Real-time continuous glucose monitoring, also known as CGM, can be done through measurement of interstitial glucose. This is fairly close to plasma glucose. CGM and insulin pumps can be used separately or as a complete system for glucose monitoring and insulin delivery. Research has demonstrated that lowering an A1C level to 6.5% is associated with decreased microvascular complications. This includes eye, kidney, and nerve diseases due to diabetes. The protocol for control of diabetes mellitus is highly individualized and depends on the type of diabetes a person has, their age, general state of health, their ability to follow the prescribed regimen, and acceptance of responsibility for managing their illness, as well as a host of other factors. The overall goal of diabetes management is achieved when fasting glucose stays within normal limits. The A1C shows that blood glucose has stayed within the normal limits from one testing period to the next. The patient's weight should be normal, blood lipids should remain within normal limits, and the patient should have a sense of health and good well-being. On page 885, see the red older adult care points box. Older adults will experience hypoglycemia more quickly than younger people, and older adults will be more prone to hypoglycemic episodes. Older adults can progress to dangerously low levels of blood glucose before signs and symptoms are obvious. Severe hypoglycemia in the older adult can precipitate MI, angina, stroke, or seizures. For this reason, tight control may not be the best option for older adults. Diet is the cornerstone of diabetic treatment. Weight gain can make a patient with type 2 diabetes more insulin resistant. In many cases, people with type 2 diabetes can control their blood glucose by reducing their caloric intake and increasing their physical exercise. The primary goal of a diabetic diet is adequate nutrition with weight control. The strategies that can be effective in managing diabetes can be altered by many different factors, and the strategies that are effective for one person may not be effective for someone else. Medical nutrition therapy, or MNT, is recommended for all patients with type 1 or type 2 diabetes. This consists of a registered dietitian or a certified diabetes educator performing an in-depth assessment of the type of diabetes, the patient's height to weight ratio, their usual dietary intake, food preferences, their exercise level, and their daily schedule. They will then design interventions to reduce fat intake, carbohydrate counting, simplified meal plans, make healthy food choices, provide individualized meal planning strategies, exchange lists, create insulin to carbohydrate ratios, physical activity, and developing behavioral strategies. In general, MNT is aimed at providing adequate nutrition with sufficient calories to maintain a normal body weight and control of cholesterol, and at adjusting the intake of food so that blood glucose can be kept within safe limits. For patients with diabetes, distribution of calories is important for glycemic control. Breakfast calories should be 20% of the daily allotment, with lunch at 35%, dinner at 30%, and a late evening snack at 15%. If the patient chooses to eat sweets, they can be substituted for carbohydrates and should not exceed 10 to 35% of the total energy intake. This should not have a negative effect. Protein should make up 15 to 20%. For patients with diabetic nephropathy, this is a kidney disease secondary to the hyperglycemia, a protein intake of 1 gram per kilogram of body weight is recommended. Reduction of saturated fats, trans fats, and dietary cholesterol will also improve cardiovascular outcomes. Cultural preferences must be considered when devising these meal plans. One of the most effective means of helping a person with diabetes follow their prescribed diet is by teaching them about the food values and how it affects their diabetes. Physical exercise is an important part of managing diabetes. In addition to lowering blood glucose levels by burning up the glucose, exercise will make insulin receptors on the cells more sensitive to the hormone, therefore improving the use of the available glucose. Exercise has been shown to improve glycemic control in type 2 diabetes. Even people with type 1 diabetes can decrease their cardiovascular risk through regular exercise, although it does not contribute to their control of blood sugar. The exercise program should be designed for the individual patient. The plan should consider the patient's age and their overall physical condition, their ability to carry out exercises regularly, and how well controlled their diabetes is. All exercise programs should begin with milder forms of exercise and then gradually increase to the patient's level of tolerance or until the desired therapeutic effect has been reached. A program should not be started until blood glucose is under control. The exercise program should be planned so that exercises are performed at the same time every day, preferably after a meal when the blood glucose is highest. Blood glucose should be checked before beginning exercise. General guidelines for exercise would include practicing good foot care and wearing appropriate shoes and socks. Managing blood sugar during exercise will be individualized to each patient and considers whether or not it is type 1 or type 2 diabetes. Key guidelines for safe exercise will include knowing your blood glucose before the exercise. Snacks should be included and used during activity to prevent hypoglycemia. A liquid or other readily absorbed source of carbohydrate is recommended. Performing exercise when insulin or an oral anti-diabetic agent is at its peak of action could bring on an acute hypoglycemic reaction. Eating a piece of fruit, even before light exercise or done between meals, could help prevent hypoglycemia in patients with type 1 diabetes. Patients should keep a daily record of their exercise, along with their weight, insulin dosage, and blood glucose levels. This can help motivate the patient to continue their exercise. Oral hypoglycemic agents, or OHAs, or anti-diabetic agents could be prescribed for patients with type 2 diabetes to manage their glucose levels. Patients receiving OHAs should know that these medications will not eliminate the need for a diet and exercise program. All OHAs can produce gastric irritation, nausea, vomiting, and diarrhea. During illness and any changes in routine, insulin may be added to inpatient hospital treatment. Most patients with type 2 diabetes controlled by OHAs will be able to return to their typical medication regimen after the acute episode has been resolved, and they usually will not need long-term injectable insulin. Insulin therapy can be prescribed for patients with either type 1 or type 2 diabetes. The goal of insulin therapy is to closely mimic basal insulin. This is the amount of insulin that would normally be produced by the pancreas throughout the day to maintain healthy blood sugar levels between meals. The pancreas also produces extra insulin after meals. This is known as postprandial. The multiple daily injection, or MDI regimen, is frequently prescribed and does offer the advantage of being more physiologically appropriate. MDI will combine short and intermediate acting insulins injected typically 2 to 3 times per day. A bolus dose or correction dose of short or rapid acting insulin can be used to manage elevations in blood glucose and bring the next blood glucose measurement into a normal range. Higher concentrations of insulin are used so that large volumes of solution do not have to be injected for patients who require a higher insulin dose. Insulin cannot be taken orally or be given via a feeding tube because it will be destroyed by gastric juices. An inhaled rapid-acting insulin is actually now available. Insulin pens filled with insulin are another alternative to the traditional syringe and needle apparatus. Injectable insulin continues to be the most common delivery method, so it is critical that you be educated in all aspects of injectable insulin therapy. Insulin injections should be rotated from one body to another to enhance the absorption. You can see this diagram on page 891 showing the rotation sites for the injection of insulin. Note how the darker blue is recommended, but the lighter blue is also possible. Insulin enters the bloodstream at different speeds when given at different sites. The abdomen will have the quickest absorption rate, then followed by the upper arms. The thighs and buttocks will have the slowest absorption unless the injection is given before exercise, when blood flow to those areas will be increased. Patients are encouraged to keep a daily record of their injection sites to help them remember which sites have been used and prevent the problem of altered or erratic absorption. Insulin requirements will change as the metabolic needs change. This can be due to diet, exercise, age, or even changes in the seasons. Insulin requirements will also be altered whenever the patient has an infection, illness, or is under added stress. An alternative to insulin therapy by daily injections is the insulin pump. These pumps can deliver a continuous infusion of insulin through an automated system composed of battery-driven electronic brain, an electronic motor, and drive mechanisms. A syringe will be attached to plastic tubing, and a subcutaneous needle will be inserted into the abdomen or thigh. These pumps can be helpful in managing diabetes because they allow for improved blood glucose control. People using pumps will tend to have fewer episodes of and less severe hypoglycemia compared to those using MDIs. The pump will continuously deliver basal insulin to maintain blood sugar levels between meals. It can even be programmed to administer a bolus dose for meals or an elevated blood sugar level. Insulin pumps are recommended for patients who are willing and able to monitor their glucose frequently during the day and who can understand the principles of basal and bolus insulin as well as carbohydrate counting. There are new injectable agents that have been introduced. Although these will not replace the standard diabetic medications, they should be used to enhance the effect of existing medications. One new category of medications is known as the incretin mimetics. This is because they mimic the action of incretins. These are hormones released from the intestine. In type 2 diabetics, they can lower postprandial blood glucose in a different number of ways. Other injectable medications to treat diabetes include synthetic hormones, like Symlin. These can be used in type 1 and type 2 diabetes. Although these medications are administered subcutaneously, none of these medications should ever be mixed in the same syringe as insulin, and the patient must be monitored carefully for hypoglycemia. The emotional and physical stress of surgery can increase the blood glucose level and alter the amounts of medication needed for glycemic control. Patients with type 2 diabetes may be taken off their OHAs up to 48 hours before surgery and then started on insulin by injection to achieve adequate control of their diabetes during a stressful period. For all patients with diabetes, IV fluid should be started as soon as the patient has been ordered NPO. They should be continued until after the patient has begun eating again after the surgery. Blood glucose will be monitored closely during surgery and again every 2 to 4 hours postoperatively. The urine should be checked for any ketones whenever glucose levels are high. Replacement of islet cell insulin production can be achieved by transplantation of insulin-producing islet cells or transplantation of the entire pancreas. Lifelong immunosuppressive medications will still be needed to prevent rejection for either procedure. In the first year following transplant, whole organ transplant patients had a higher insulin independence rate at about 75% compared to patients who received the islet cell transplantation of about 57%. After 5 years post-transplant, both procedures were at approximately 67% success. Many times, a pancreas and kidney transplantation will be performed together using organs from the same donor. Altered renal function is a complication of type 1 diabetes, and transplantation of both organs will result in a better outcome. On page 893, see the red safety alert about hyperglycemia or hypoglycemia. When there is doubt as to whether a patient is experiencing hyperglycemia or hypoglycemia, treatment should be begun for hypoglycemia until a blood glucose determination is obtained to prevent any brain damage due to extremely low cerebral glucose levels. Caution should be used not to overtreat with glucose. Hyperglycemia can worsen neurologic conditions. A rapid determination of blood glucose will be essential to proper management. Hyperglycemia will typically develop slowly and will not cause immediate changes in LOC. However, hypoglycemia can occur rapidly and cause very significant changes in level of consciousness. In general, people with diabetes are susceptible to two types of complications. This would be short-term and long-term problems. Acute complications, or short-term, will arise when the blood glucose suddenly becomes either too high or too low. Type 1 diabetes is more likely to be complicated by ketoacidosis, whereas type 2 diabetes can cause hyperglycemic hyperosmolar state, also known as HHS. Diabetic ketoacidosis, or DKA, is a serious condition caused by incomplete metabolism of fats resulting from an absence or an insufficient supply of insulin. In an attempt to rid itself of acidosis produced by the ketones, the body increases respiratory rate and depth. This is known as Kussmaul's respirations. Acetone, a ketone body, will be excreted in the urine, causing acetonuria or ketonuria, as well as from the lungs. This can be detected in the characteristic fruity odor to the breath. As the kidney excretes excess glucose and ketones, it also eliminates large quantities of water and electrolytes. These pathologic changes are responsible for metabolic acidosis, dehydration, and electrolyte imbalances. Signs and symptoms of DKA can be life-threatening. Electrolytes, especially potassium and serum glucose, will be monitored closely. In the absence of insulin, potassium will come out of the cells, and patients will present with hyperkalemia. As the IV fluids are given and insulin administered, potassium will return to the cells, causing hypokalemia. These potassium shifts are very important to monitor and manage so that lethal cardiac dysrhythmias will not occur. The goals of treatment are to restore the normal pH of the blood and other body fluids, correct fluid and electrolyte imbalances, lower the blood glucose level gradually, and provide life support measures as necessary. Infection is the most common cause of DKA. However, other causes can include poor compliance with the prescribed regimen of diet and insulin therapy, as well as insulin pump failure. After the patient has been stabilized, the underlying cause must be determined and treatment or corrective measures implemented. Hyperglycemic hyperosmolar state, or HHS, occurs primarily in patients with type 2 diabetes experiencing high blood glucose levels due to illness or added stress, like an infection. The glucose levels will be greater than 600 milligrams per deciliter, and in some cases can even reach over 1,000. The extremely high level of glucose within the blood causes severe dehydration and circulating fluid volume depletion secondary to osmotic diuresis. Because ketones and acidosis are absent, the GI symptoms will not occur, and the patient may not seek medical care early in the course of illness. The patient's mental state may progress from confusion to a complete coma. Also, in contrast to DKA, a patient in HHS could experience generalized or focal seizures. Things that could precipitate HHS in a patient with type 2 diabetes include medications that increase serum glucose levels or cause dehydration, like steroids, acute illnesses such as infection, MI, and stroke, chronic illnesses like CHF and renal dysfunction, and treatments like TPN or peritoneal dialysis. Treatment of HHS will focus on fluid replacement and correction of electrolyte imbalance. Because fluid replacement will initially be rapid, cardiovascular status and lung sounds must be assessed frequently. The underlying illness that triggered the HHS must be identified and treated. HHS can be fatal, and the mortality risk is directly correlated with higher elevations of blood glucose and the resultant severity of dehydration. Rebound hyperglycemia, also known as the Somogyi effect, follows a period of hypoglycemia that often occurs during sleep. The patient might report nightmares and night sweats, along with a morning elevated serum glucose. The patient will increase their insulin dose, and it actually worsens the problem. The Somogyi effect can be diagnosed by checking blood sugars throughout the night. Once this is verified, the typical treatment is to lower the insulin dosage or move the time of the intermediate-acting insulin to bedtime. The dawn phenomenon is characterized by elevated blood glucose in the morning. This is caused by release of growth hormone, glucagon, and epinephrine throughout the night. This is part of the body's natural circadian rhythm. These hormones will act to raise the body's blood sugar, and the treatment is an intermediate-acting insulin at night. Most often, hypoglycemia will be a response to either too large a dose of insulin or too much exercise in relation to the amount of food eaten. Patients with diabetes should be taught to monitor for signs and symptoms of hypoglycemia. This includes tremulousness, hunger, headache, pallor, sweating, palpitations, blurred vision, and weakness. These symptoms can progress to confusion and loss of consciousness. Individual reactions will vary considerably. Some patients could be totally alert with a glucose level of 40, whereas others will be comatose at this level. Treatment will depend on the degree of hypoglycemia and the patient's level of consciousness. If the patient is alert enough to tolerate oral intake safely, this would apply to glucose levels of 40 to 60, can respond to ingestion of food like milk, crackers, or juice. A glucose level of 20 to 40 will respond best to concentrated sugars like honey, table sugar, or juice. These patients should be taught how to self-treat their hypoglycemia. The long-term consequences of diabetes mellitus are chiefly the result of damage to large and small blood vessels. This is known as macrovascular and microvascular. Elevated blood glucose levels over a period of years will seriously damage blood vessels and the organs that they serve. Diabetes is the seventh leading cause of death within the United States for all age groups. In addition, cardiovascular disease and other causes of death can be attributed to diabetes. Damage to the mechanisms that control blood vessel health will occur when blood glucose is elevated over a long period of time. The alterations in the macrovascular system will eventually result in coronary artery disease, peripheral artery disease, and stroke. Microvascular complications can result from damage to the small vessels at the capillary level. This causes diabetic nephropathy, neuropathy, and retinopathy. The less closely the blood glucose has been controlled, the more likely the patient is to develop cardiovascular, eye, and renal complications. Improperly treated or untreated diabetes is the leading cause of new blindness, renal failure leading to dialysis, and non-traumatic lower limb amputations. 2 in 3 patients with diabetes will die prematurely from heart attack or stroke. Tight glycemic control is the best strategy to prevent vascular changes that will cause an MI and stroke. Gangrene, which typically leads to amputation, is far more common in patients with diabetes. More than 60% of non-traumatic amputations will occur among patients with diabetes. Vascular changes will typically cause very poor circulation in the feet and lower extremities. Because increased levels of glucose in the blood provide a good medium for bacterial growth as well as decrease the immune response, it'll be harder to eradicate infection. Learning and practicing excellent foot care is essential to preventing amputation. Diabetic nephropathy will occur directly from changes in renal blood circulation. Factors that influence whether a person with diabetes will develop kidney disease includes genetics, blood glucose level, and blood pressure. After years of having to filter too much blood with an elevated blood glucose, the filtering mechanism of the kidneys will begin to fail, allowing large particles that would have normally been filtered out to exit through the urine. In the early phases of albuminuria, there are small amounts of protein in the urine. If nothing is done to prevent further damage, increasing amounts of protein will be excreted within the urine. Finally, the patient will enter end-stage renal disease, requiring either a kidney transplant or dialysis to perform filtering for the kidneys. Nephropathy can be delayed and possibly prevented by keeping a tight control of blood glucose. In patients with type 1 diabetes and early albuminuria and hypertension, ACE inhibitors have been shown to be beneficial in slowing the elevation of the albuminuria. Visual impairment and blindness are common sequelae of diabetes mellitus. The 3 most common visual problems include diabetic retinopathy, cataracts, and glaucoma. Retinal damage, which can cause visual impairment and blindness, will occur in most patients with diabetes within 20 years of their diagnosis. Tight glucose control, frequent eye examinations, and treatment will help preserve vision. Approximately 60 to 70% of patients with diabetes have mild to severe neuropathy. Pathologic changes within the nervous system cause symptoms like paresthesia, numbness, and loss of function. Diabetic neuropathy primarily affects the peripheral nerves, causing sexual impotence in men, constipation, neurogenic bladder, and pain or anesthesia in the lower extremities. It is for this reason that foot care and daily inspection of the feet are so important. Because the patient often cannot feel cuts, blisters, or abrasions on their feet, there will be a greater danger that a neglected sore could become infected. In contrast, some patients experience debilitating pain and hyperesthesia. Some actually lose their deep tendon reflexes. No single therapy has been shown to effectively treat pain from diabetic neuropathy. Other problems related to diabetic neuropathies are the result of autonomic nervous system involvement. These would include orthostatic hypotension, delayed gastric emptying or gastroparesis, diarrhea or constipation, and asymptomatic retention of urine in the bladder. Assess every patient for signs and symptoms of potential diabetes mellitus. For a patient newly diagnosed with diabetes, you should assess whether the patient is a good candidate for using a glucometer. Manual dexterity will be needed to perform the finger stick needed to obtain a blood sample, place the blood in the right spot, and then correctly read the meter. Patients with arthritis or a visual impairment could have difficulty with these steps. The patient must be able to remember the correct sequence of the steps and remember to do it at designated times. CGM could be used for those patients unable to manage a glucometer. When caring for a patient with diabetes, you should know the schedule for meal tray delivery and plan glucose testing and insulin injections for those appropriate times. Finger sticks for blood glucose testing should be performed 30 minutes before breakfast. If 1 hour has elapsed without the insulin being given after the initial reading was obtained, the glucose test must be repeated again before insulin administration. If rapid-acting insulin is ordered, it should not be given until the food tray is actually in front of the patient. The insulin dose should be adjusted according to the healthcare provider's order during any NPO periods. The insulin should not be withheld. To prevent any delays, make certain that your patient's insulin, appropriate syringes, or other oral medication are readily available. Interventions will be geared towards assisting the patient with self-care, performing their blood glucose determinations, administering medication when the patient is ill and cannot self-administer, observing for signs and symptoms of complications, assessing learning needs, and carrying out a teaching plan as indicated. Be sure to encourage others involved in the patient's care to be alert for any signs and symptoms. Intake and output recordings are appropriate if the patient is ill or having surgery. Any type of stress can alter the patient's control of their diabetes. After injection of each type of insulin, you must know when the hypoglycemia might occur and should then assess the patient at that time. Monitoring for signs of ketoacidosis is also seen as essential. Some of the earliest signs could be polyuria, fatigue, anorexia, abdominal pain, and a fruity smell to the breath. The patient should be able to self-manage their diet, medication, and progress. In addition, adjustments in lifestyle, recreational choices, and self-image will probably need to be made. Non-adherence to the treatment plan can be devastating to a patient's welfare and can mean the difference between leading a normal life or becoming an invalid. Eventually, not managing the disease could mean the difference between life and death for a patient with diabetes. Major topics to be covered in a standardized program would typically include the following: the pathophysiology of diabetes, including functions of the pancreas and any contributing or precipitating factors, how to manage a diet program, blood glucose monitoring at home, foot care, urine testing when the blood glucose level is higher than 240, identification tag, ID card, and medical information. Information on what to do on sick days, especially when feeling nauseated or vomiting and unable to maintain the diet. Community resources and help groups available. Travel tips, and devices that make insulin administration easier. The patient and significant others, staff nurses, healthcare providers, diabetic specialists, nurse educator, dietitian, podiatrist, and periodontist should all be involved in the educational process. Evaluation. Monitor the A1C and fructosamine assay levels to determine the degree of control over the blood glucose. Observe demonstrations of learned skills for insulin injection, proper foot care, dietary planning, and glucose monitoring. The organs involved in meeting the challenge of carbohydrate ingestion include the intestines, liver, and pancreas. Therefore, any condition affecting these organs and their systems could lead to hypoglycemia. Examples other than diabetes mellitus would include a gastrectomy or surgical bypass procedures. People who abuse alcohol and other substances are also prone to hypoglycemia. Signs and symptoms of hypoglycemia include rapid heartbeat, tremulousness, weakness, anxiety, nervousness, and hunger. These symptoms could occur rather suddenly, within 4 hours after a meal has been eaten. These symptoms will include irritability, personality change, temper tantrums, and other psychoneurotic manifestations. Diagnosis of hypoglycemia is made with measurement of blood glucose values. Hypoglycemia can be treated by modifying the eating patterns. Smaller and more frequent meals that are relatively free of simple sugars are recommended. The diet should be high in proteins and low in carbohydrates. The carbohydrates should be complex, like those found in whole fruits, vegetables, and whole grains. Refined sugar and white flour should be omitted. Untreated fasting hypoglycemia can lead to severe neuroglycopenia. This is a shortage of glucose in the brain and possibly death. In addition to information about the patient's physical and mental symptoms, assessment should include a detailed history of eating habits. Nursing interventions for patients with hypoglycemia include explaining the nature of the disorder, as well as the need for any diagnostic testing, objective observation and reporting of symptoms, and reinforcement of dietary instruction and restrictions. Nurses will play a crucial role in home care and in teaching the older adult population who has diabetes. Long-term care nurses should be alert to the signs of diabetes. Home care and clinic nurses should be persistent in assessing compliance with diabetic regimens and must also be instrumental in teaching the public about signs and symptoms of diabetes, as well as self-care to prevent any complications.